Kate Jackson is the Director of Older People's Mental Health Policy, Mental Health Branch, New South Wales Ministry of Health. Here's Kate. She's been around for a little while. She's been doing this for some number of years, and she's going to give us a good presentation on what she's been doing. So thank you.
Thanks, Kim, and it's great to be here today. I'd like to acknowledge the traditional custodians of the land on which we're meeting today and pay my respects to Aboriginal elders past and present, and any other Aboriginal people who may be present in the room. And I also want to acknowledge the people with lived experience of mental illness, and that those perspectives are important and fundamental to everything that we do. And I wanted to note that we are still on a journey, I think it's fair to say, in older people's mental health in New South Wales in terms of better engaging consumers in our services. But we are getting better at this, and it is a key focus for us going forward. I wanted to just say that, reflecting on some of the other presentations that we've had here, that this presentation is going to cover a bit of data and evidence, so prepare yourself, about the need for action around physical health care for older people with mental illness. So it is a bit different from some of the other presentations in that sense. And we do this because I think part of understanding what you might need to do in terms of focusing activity and action in this area is understanding what are the issues for your target group and for the services that you're working with. And also because older people with mental illness don't tend to get very much specific attention in policy and in discussions like this. So well done for being here. Thank you for your interest, hopefully in older people with mental illness, as well as the broader area of physical health in people with mental illness. And so I will draw, though, from some of that evidence about what can we take from that in terms of lessons of implementation, and Rod's presentation after mine will build on that as well. So this is a brief overview of my presentation. I better get it up, hadn't I? There you go. So I'm going to talk about our ageing population, a bit of data about physical health and mental health in older people. I'm going to look at some of the published evidence about the physical health needs of older people with mental illness. Then I'll give you a few insights into how we're responding to those physical health needs, and briefly summarise from that what does that mean for care and for implementation action. Oh, gone the wrong way. There you go. So there are lots of ways of looking at our ageing population. We all know our Australian population is ageing. This is quite a people-centred way of looking at it. So in 1911, only 4 out of 100 Australians were over 65 years, and by 2011, 100 years later, that had risen to 17 out of every 100 people, and that figure or proportion is increasing. So in fact, people are living 7 years longer now than they were in the mid-1960s, and those are additional healthy years. So all of that is good news, and I'm going to come back to some of that. And what that means, though, is that, of course, we need to gear up for addressing the needs of a much larger group of people. This is something that we talk about a lot in older people's mental health policy. So older people's mental health and physical health care is a growth area. So population ageing. These are some figures from New South Wales, population figures and projections for people 65 years and over, but it's a bit more of a differentiated perspective, so it's 10-year age groups from 1971 to 2036. Don't worry if you can't see the numbers down the bottom, because it is about the trends. The blue section there is the last 5 years, so 2013 to 17. And what we can see is that the younger old group, that is the 65 to 74-year-olds, and that's the red line there, are the largest group, and that group has been growing at the fastest rate. But the rate of growth for the older old age groups, 75 to 84, and which is the green line, and the purple line, 85 years plus, is increasing. So that's significant because in general the Australian population is ageing well, and the younger old experience better physical health. Although noting, of course, that people with mental illness often have early ageing issues, particularly where they've had an enduring mental illness and complex health conditions associated with their illness and treatment. And of course, we've talked a lot about that in the last 2 days. But the growing older old population is likely to present with more complex coexisting health conditions. And so where those people have mental health issues, integrated approaches to mental health and physical health care are particularly important. And for older people's mental health services, which is an area that I'm particularly responsible for, the demographic drive to the older Australians is likely to lead to the numbers of people being referred to older people's mental health services with complex coexisting conditions increasing. And so we need to plan to be able to respond to that. And so what does that mean for care? Well, in considering the physical health care of older people with mental illness, we need to consider the needs of those different groups, and they are potentially quite different, and tailor our approaches accordingly. Also, older people with mental illness, of course, are a diverse group, but one way that you can look at that group is that the people with severe and enduring mental illness that they have taken through life, and those who grow older with a continuing experience, and those who develop mental illness in later life. And older people who grow old with a continuing experience of mental illness, particularly severe mental illness, tend to have more of the disadvantage around accessing appropriate physical health care, assessment and care, and as well as the effects of their treatment and illness over a lifetime. Whereas older people who've developed mental illness in later life generally have a better history of healthcare management, but the issue more for them is often getting their mental health needs recognised within and not overshadowed by their physical health needs. And so integrated care is no less important for those people. And this relates to to a comment that was made earlier. Let's not just focus on the negatives in some way. We need to be careful that in focusing on the physical health needs of people with mental illness, older people in particular, we don't reinforce those potentially ageist and negative views of ageing. So older people make actually a significant contribution to Australian society, and as this data shows, they provide a significant proportion of childcare, they have high rates of social participation, and they're very involved in voluntary work. And older people are often very resilient, and age actually has a protective effect on mental health. So contrary to many preconceptions that depression is a normal part of ageing, and you sometimes do actually hear that expressed, later life is actually a time of improved mental health for many people, and rates of mental illness are actually lower than they are in younger people. But some groups of older people are more prone to mental health issues than others. For example, people in residential aged care facilities, and we're hearing a little bit about this in the news at the moment with the Royal Commission. And men over 85 have consistently had high rates of suicide over the last 10 years, a fact which doesn't often get expressed out there. And if we look at physical health and mental health comorbidity in older people, we can see that comorbidity rises dramatically in older people with mental illness, from 10% in people under 45 to 60% in people over 65 years. So given that, we really can't afford to ignore the need for physical health assessment and care for older people with mental illness, and integrated physical and mental health care really is, as they say, core business. Looking at mortality in older people with mental illness, each year more people aged 65 to 85 years living with mental illness, which is the blue column there, die than the rest of the population within that age range. So early death is a significant risk issue for older people with mental illness. And if we look at the treatment patterns, the percentage of people accessing MBS and PBS mental health treatments goes up for people 65 plus years, but note that this is mainly due to higher rates of medication in older people rather than psychological therapies, and there are lots of challenges in older people accessing appropriate psychological therapies, and that can be problematic, of course, for physical health care around falls and multiple medication use. The relationship between physical health, mental health and mortality risk is complicated though, and changes in mortality risk for people with mental illness aren't actually simply age-related, of course. Still, it's clear that poor physical health is the largest contributor to poor mental health in older people, as this large cross-sectional study by Lorem et al. Shows, and that underlines the importance of integrated physical and mental health care in older people to address both the mental health risks and the physical health risks. So looking at the international literature, what do we know about the physical health needs of older people with mental illness? Well, we know that some psychiatric medications increase the risk of a range of physical health conditions. This is not new to any of you, such as diabetes and cardiovascular disease. We know that older age and polypharmacy, which is common in older people, as well as higher dosages, are associated with increased risk for most of those diseases. And I've already noted the association between physical ill health and mental ill health in older people. This New South Wales Health guideline for mental health services about physical health care for older mental health or for mental health consumers highlights, in fact, some of the particular risks and challenges for this group. So risks associated with falls and multiple medication use, for instance, potential challenges around obtaining an accurate and complete physical health history, and the importance of considering delirium in older people presenting with apparent psychiatric conditions. And we know that this kind of more specific guidance is important because there are things that are different when you're treating older people from younger people. And drilling down a bit further, this Danish study of older people with schizophrenia found that this group had a similar profile to the control group in terms of chronic illnesses, but were much less likely to receive medication for cardiovascular diseases. They also had similar patterns of hospitalisation to the control group, but much less primary care, much less GP care. And a Dutch study of people with schizophrenia found that excess mortality associated with schizophrenia continues into later life, affecting men more than women. So there's something to look at there. And closer to home, this isn't summarised on the slide, but a major Western Australian study of older men with depression found that they had a higher risk of hospital admission for non-psychiatric conditions and were more likely to have longer hospital admissions and worse hospital outcomes. So that potentially highlights a potential area to target health interventions for that particularly high-risk group. So if we're thinking about areas for implementation and for action, let's look at some of those high-risk groups. A number of studies also highlight the higher frequency of metabolic syndrome in older people with severe mental illness. And this Canadian study of older people with co-occurring anxiety and physical health conditions highlights the complex connection really with mental health service use. So, getting to how are we going in terms of meeting physical health needs of older people with mental illness? Well, the answer from this study in the British Journal of Psychiatry of older people with schizophrenia is not very well. This study showed under-assessment and under-treatment of physical health conditions despite the known risks. And this UK study looked at clinician attitudes towards older people with severe mental illness and physical illness, and it found that clinicians found this combination challenging, that they're unclear about different responsibilities. This echoes some of the themes we heard yesterday, and they feel they need more collaboration and more education. So let's talk about how older people's mental health services are responding to physical health needs. This is national HONOS data for older people's mental health inpatient units. It shows that in the course of an inpatient stay, the clinician-rated health status of most, that is about half consumers of older people's mental health inpatient services, stays about the same. More get better than worse, which is encouraging. But there is a small group that gets worse, and it's for those that deteriorate in inpatient care that we really need to look at what we can do to prevent that deterioration. And this slide tells a similar story to the last slide, but it relates to activities of daily living and physical function. And again, for those that deteriorate in terms of ADLs in inpatient care, we need to look at what we can do to prevent that deterioration. And this is the kind of information that we look at within our older people's mental health services in our benchmarking strategies, and Rod will talk a little bit about that. So for a few more insights about how older people's mental health services are currently responding to the physical health needs of consumers, and again, Rod will talk about this in a little bit more detail. We have a statewide older people's mental health benchmarking strategy in New South Wales, and as part of that, we have developed self-audit tools for our community and inpatient services, which outline some good practice standards in a range of areas that are aligned with statewide evidence-based models of care. And we conduct self-audit processes annually with almost all teams across across New South Wales opting into the process. So there's a high level of engagement with this. And the results of those self-audit in terms of physical health issues show that older people's mental health services are challenged in a number of standards relating to physical health care. So they're challenged around the involvement of GPs, they're challenged around access to nursing staff trained in IV medication and fluids and subcut fluids in inpatient settings. They're challenged around physical examination of older consumers, particularly in community services, and they're challenged around actions about falls prevention, especially in community services, less so in inpatient services. And we've also had a recent independent evaluation of our initial implementation of a statewide model of care for our community older people's mental health services. And that confirms from staff survey and so on the challenges our clinicians are identifying around physical health assessment, around accessing skilled staff for assessment and management of physical health issues, and some of the other self-audit tool findings. And we can get some more insights from consumer experience surveys. So in New South Wales, the measure of consumer experience of mental health services, the Yes, Your Experience of Service questionnaire includes a specific set of questions about physical health care. And I think in our conference bags, you've got a copy of that Yes survey with the New South Wales specific questions. And the Yes survey results for older people's mental health services give us a bit of an insight too. And they show that in general, older people's mental health services provide a high level of information and advice to consumers about healthy eating and diet and exercise and physical activity. This is as reported by consumers. They provide a medium level of information about possible side effects of medications. That's slightly better in our community services, about alcohol and drug use, again better in community services, and about smoking where that's relevant. They provide limited information and advice about sexual health. And overall, despite all of that, which you might see some gaps in some of that information and advice that's provided in the physical healthcare area, people are overall have a very high satisfaction rate with older people's mental health services, and that echoes the UK study that I mentioned earlier. So, to summarise in terms of implementation action and what all of this means for care, our ageing population means that we need to be geared up for addressing the needs of a growing group of older people, and older people's mental health and physical health care is a growth area for us. In considering how and where we target our action, we need to consider the needs of different subgroups of older people. All older people are not alike. And apart from individualised care, we need to look at the needs of different groups. So the younger old and the older old may have some different kinds of needs, and different sorts of strategies might be appropriate. Given the high levels of physical health and physical and mental health comorbidity in older people, integrated care is really a no-brainer. We need to understand the risks and complexities that are specific to older people with mental illness, And as I said earlier, this is often a gap in policy and practice guidance. There's often not so much consideration of how this guidance particularly applies to older people. And given the evidence from the literature, we could do worse than improving assessment and treatment in known physical health risk areas, such as cardiovascular conditions. And we should look at, within our services, at older people's mental health services, at our attitudes to physical health care and collaborative care, at our staff skills, mix and staffing profiles, at collaboration, particularly with GPs, and advice to staff to consumers on physical health issues, on things like medication use. And I'm really going to finish with this slide because it's a bit of a taster for Rod's presentation and also for our workshop this afternoon. It just gives you one kind of framework for looking at implementation priorities. And Rod's going to talk you through the implementation journey that we've had in New South Wales in this work. Thanks.